Now, and let me share my screen. And thank you so very much. Today's talk is refractory hypotension, inotropes, what and why, and some refractory strategies, some pragmatic strategies that we can utilize when we're making decisions about inotropes, about titration, about how to prepare effectively, and how to understand what might be presenting itself when we're looking at our patients. So it is really important to remember that typically the very first step when you have a patient who is hypotensive is to administer fluids. And if they are also hypotensive, because they might be hypoperfused, but if they're also hypotensive, to actually then consider the administration of low dose vasopressors, because you want to remember, we're not going to allow patients to have even 1 minute of hypotension. Even 1 minute of hypotension can confer some mortality and morbidity issues for our patients. So very, very important when we're thinking about hypotension in our patients and how we're always going to be aware of that, how we're going to consider very early on the application of low dose vasopressors. Now, if your patient continues to be hypoperfused or hypotension after you have administered fluid to a patient who has a fluid response, and then you start on low dose vasopressors, you need to ask some questions, not just assume that you should further titrate up on your vasopressor, but you need to ask some questions. You might have to go up on your vasopressors, but the questions will really be, does this patient actually need inotropic support? And quite often, inotropic support is added way late in the game when there might be an indicator early on that that would be beneficial. Do they actually need blood products? And I've noticed that in some of the talks that I give, people will say, well, we don't give blood unless the hemoglobin's less than 7 or unless the hemoglobin's less than 8. And the thing is, all of the studies about hemoglobin resuscitation were based on not having a target number, but having an individualized approach that most people who are not critically ill, who do not have tissue hypoperfusion, meaning refractory metabolic acidosis, a significant base deficit, if your patient doesn't have those presentations, letting their hemoglobin go to 8 or 7 is okay. But in patients who have refractory metabolic acidosis with hypoperfusion, they actually need for you all at the bedside to actually advocate for the administration of blood products. Now, it is really important to remember that administering packed cells to a patient actually will increase oxygen carrying capacity, but more than 2 units of packed cells will overwhelm the capability that the patient has to actually release the oxygen from the hemoglobin. It will take them 1 to 3 days to make enough enzyme to push the oxygen off of their hemoglobin. So we always have to do this with very clear minds. I have a patient who I have administered fluid. They are no longer fluid responsive. We call that now, they're fluid refractory. They're on low dose vasopressor. I've added some low dose inotropy, and they continue to be with refractory metabolic acidosis, highly linked to lactic acidosis. I'm going to administer blood, but I'm only going to administer 1 to 2 units of packed cells every 48 hours, if I even need that much, because I want to remember, I'll feel like the arterial set will look better, but they won't be able to release oxygen from the hemoglobin. They don't have the enzyme that's necessary. For people who take any exam or are taking their nurse practitioner exam, their CEN exam, their flight nurse exam, their trauma nurse exam, CCRN, PCCN, there sometimes is a reference to this. That hormone, that enzyme is called 2,3-DPG. It's a biphosphoglycerate, biphosphoglycerate molecule, and it's very dependent on phosphorus and nutritional support. And we have a very small amount of it in vivo. So when I give red cells, I have to be sure I understand that I may overwhelm their capability to release that oxygen from hemoglobin. So that's a really, really, really important perspective. The next thing I'll consider is, do they need hormonal intervention? If they have hypoperfusion or hypotension, after I've given fluids and low dose vasopressor, before I titrate up, I'm going to consider, do they need some type of hormonal replacement? Now that would be 100 milligrams of Solu-Cortef as a bolus. It would be also vasopressin and 0.04 mics per or units per minute, or it could be angiotensin. And remember that angiotensin is the most potent vasopressor known to man, and it's quite expensive and it requires a pharmacy sign off. You would only use that in individuals who did not have cardiogenic shock. You can use it just about in any other case, but not in cardiogenic shock. It's an excellent treatment for vasoplegia. It's an excellent treatment for metabolic acidosis-induced vasodilation, but it is not an excellent treatment for patients who have cardiogenic shock. Okay, so I just want to make sure everyone remembers that metabolic acidosis makes all of your sympathetic sites resistant. So if you have a question like, why is it that sometimes when we're using vasopressors and we're titrating up and up and up and the patients don't respond? It's really important to remember that with acidosis, metabolic acidosis, the hydrogen ion, which is metabolic acid, moves into the cell and the cell releases potassium. So your serum potassium goes up a little. If you've just joined, if you don't mind, please mute yourself. This is Zoom and you have to, I can do it automatically. You don't get automatically muted, but I've muted it, no problem. Okay. So the metabolic acid hydrogen moves into the cell, and to exchange for that placement, the cell releases potassium. So your serum potassium goes up mildly to moderately, but the acidosis in the cell and the exchange for that potassium actually limits your cellular receptor sites' responsiveness to sympathetic stimulation. So that's going to mean both alpha and beta. So if we're thinking about blood pressure, any agent that is a synergistic neurotransmitter for the sympathetic stimulation, that would be epinephrine, norepinephrine, and neosynephrine, and also beta stimulation for inotropic support. So in general, for us, that will be dobutamine or very low dose dopamine or very low dose epinephrine, very low dose. So if my patient is acidotic, they'll be refractory to norepinephrine, epinephrine, neosynephrine, dobutamine, low dose dopamine, low dose epinephrine. Well, that's really a problem, because that means what's vitally important for us to appreciate and always, always, always understand is that in an acidotic environment, we have to change our expectations. We have to be much more likely to use agents that are not dependent on a homeostatic pH and therefore a normal potassium level in the cell. And then I want to remind you, there are so many important electrolytes, but in terms of vascular tone and inotropic support, the two most important ions are potassium and calcium. So one thing I want to be sure of is that we as bedside nurses, we have some providers on here too, that's so lovely, that when we have a patient who has refractory hypotension, they're on low dose vasopressors, before we do anything else, we should observe very vigilantly what the electrolytes are. And remember, the calcium we're concerned about will be the ionized calcium, which is the calcium that is free to mobilize. And if we see that a patient has a potassium level that's a little bit elevated, we correlate that back to metabolic acidosis. And we're going to remind ourselves that in a metabolic acidosis state, that you lose your receptor site responsiveness to sympathetic stimulants. Okay, so those are sympathetic stimulants, right? So that means you have to know drugs that have alpha effect, drugs that have beta effect. But there are also drugs that aren't working with that chain. Drugs like vasopressin, drugs like cortisol. We're talking about inotrope, we're talking about Milrinone. So really important in terms of making good decisions about what we're asking for, what we're titrating, how we're titrating, and what we're recognizing all comes back to calcium, true potassium, and the acidosis that makes receptor sites resistant. It is also very important to remember that at around 48 hours of high dosing of any sympathetic stimulating drugs. So again, for us in this talk, the agents we use for blood pressure and the agents that we use for inotrope are neosynephrine, norepinephrine, epinephrine, dopamine, dobutamine, and also low-dose epinephrine for inotrope. Those will all be profoundly affected. Now, lots of times people say, well, why aren't you just giving bicarb? Because bicarb is a Band-Aid, but sometimes Band-Aids hold things together. So my patient is going down the hill. I give them an amp of bicarb. Everything starts to respond. What that tells me is that they have a profound metabolic acidosis that is limiting their ability to respond to my agents. That means that the next choice I make may be outside of those sympathetic stimulation agents. So again, thinking about what I might do for blood pressure, I might now move to something like methylene blue, corticosteroids. I might move to angiotensin. I certainly would move to vasopressin, all of which will work at vascular tone in an acidotic environment. So I have four choices, really. There's no reason for you to keep titrating up on agents that your patient isn't responsive to. Let's switch to other agents, or at least let's have a discussion. And then for inotrope, the problem, of course, with inotrope is that the only pure, true inotrope that at low doses has only inotropic activity is dobutamine, which is a sympathetic stimulant. So in acidosis, you're going to lose your responsiveness to that. Adding a Milrinone or administering Milrinone, it's always important to remember, we're going to talk more about it, that Milrinone is an dilating inotrope, and the underscore is on dilating, not on inotrope. So in general, the recommendation in critical care is you add Milrinone plus dobutamine. So here again, we come to some consternation. Bicarbonate administration really should only be continuously administered in bicarb responsive states, and bicarb responsive states are primarily acute kidney injury. Intermittent administration of bicarbonate can actually improve your patient's responsiveness to your vasopressors and your inotropes, but it's very short-lived. And what I'm going to just remind you, because you know what, you're doing the best you can trying to keep a patient alive, and you might need to put them on a bicarb drip until you can get CRT on or get them dialysis in some other way, that you've got to put them on a bicarb drip. And no one's going to say, don't do it. The thing to remember is that bicarb causes a shift to the left in the oxyhemoglobin dissociation curve. So all I'm saying here is bicarb promotes hemoglobin hanging on to oxygen. That's called a shift to the left. That means if my tissues need oxygen, if I'm administering a higher dose of bicarbonate, I can limit the offload of oxygen from the hemoglobin. And what is also important, and probably even more important, is that bicarb will dissociate into CO2. So by the way, I've got a patient who's crashing. I'm doing everything I can to promote survival for the patient. He's profoundly acidotic. I give him an amp of bicarb. His blood pressure comes up and then it goes back down. His stroke volume comes up and then it goes back down. I don't know what else to do right now. I'm going to put him on a bicarb drip, but at the same time, I need to increase my minute ventilation. That's tidal volume times respiratory rate in order to promote the blowing off of carbon dioxide. And I need to be sure that he has time for exhalation. So time for exhalation is determined by flow rate. So you would just speak with your therapist and say, I want to be sure that he's going to be able to blow off CO2, and I want to be sure that he has time to blow off CO2. And your respiratory therapists, we're so lucky here in the United States to have excellent respiratory therapists. They'll adjust the ventilator so that you aren't changing metabolic acidosis for respiratory acidosis. And that does happen all the time. Okay, so that's the basic quick version of talking about vasoactive drips. The other thing that's really important, and this is so heavy on the shoulders of the ICU nurse or the nurse who's providing ICU care, and that is that you should always be reevaluating the patient. So just titrating up because patients have worsening hypotension without looking at the situation and without discussing the plan, that's actually, I really think that is, I hate to call it negligent because that sounds so profoundly negative, but it is behavior that isn't concise. That patient is depending on you, their vascular tone is depending on you, their blood flow dynamic is depending on you, and you need to start your shift by saying, here is the level of titration that I'm comfortable with, and any titration beyond that, I have to assume is indicating that the patient is no longer responding. So by the way, you started at 4 of norepi and now you're at 12 and the patient's not responding. Call someone, talk, have your lab values in front of you, know what the metabolic acid situation is, know if possible what the stroke volume is so that you can have a good discussion about what to do next. I can tell you that many times providers come back to see their patients and they're amazed and oftentimes appalled to find that patients are on 50 or 60 or 70 of norepinephrine. Just because you have an order set that allows you to titrate up that high doesn't mean that's the right way to do it. So we always want to reevaluate and have very, very good discussions about what's occurring. Okay, did I just mute myself? Okay. So I like to remind everybody that everything you do at the bedside every day, you turn a patient, they desat, that's a test. You give volume, they improve, that's a test. You titrate up on vasopressors, their blood pressure responds, but they get more acidotic, that's a test and they failed it. So everything you do, you should perceive it's a test. I need to know what I expect to have happen, and I want to see if what I expect to have happen actually does happen. And if it doesn't happen, patient failed the test, and I need to now look at other options for my patient. So yesterday, we talked a little bit, not too much, because the talk was not about fluid. We talked a little bit about loss of vascular tone and the consideration of judicious vasopressor administration and titration. And again, I'm going to reiterate this to you. You need to be more careful because we're titrating up without response, but it's causing some secondary issues. And just remember that whenever you're hyperinflamed, especially if you have volume overload, you destabilize the barriers of the vessels, and the patient now is leaking fluid into the interstitium. But what we're going to talk about today is myocardial efficiency and inotropes. So I'm really not even talking about the measurement of myocardial efficiency, which for us will be stroke volume, ejection fraction, echocardiogram. And however you measure stroke volume, because there's lots of people on here that are not from Grady. At Grady, bedside nurses measure stroke volume using FlowTrack or ClearSight. At other places, they might use the Starling, which used to be called the Cheetah. They might use Lidco or Pico or Pulsion, or they might not have that. So remember, if you don't have any way to look at stroke volume, what you're going to look at, and it's much more primitive, but you got to have something, and that will be your systolic pressure response to whatever it is that you do. Systolic pressure reflects the response of the artery to ventricular ejection. So if I'm adding an inotrope and trying to improve ventricular ejection, I don't have an A line, although I'd hate that. And I don't have a way to measure stroke volume. I'm just going to look at how your systolic pressure responds to that inotrope. Excuse me 1 minute. I'm basically living on E. cola lemon drops. Sorry about that. So I think always when we're talking about managing patients and we're thinking about what we're going to do, have to really consider 4 basic main factors that affect ventricular function and ventricular dysfunction. Okay. So first of all, anybody that had myocardial dysfunction before they came to us, they've had an MI, they've had 3 MIs, they have heart failure, they have valvular dysfunction. We already knew they had myocardial dysfunction. We're going to be on the ready to evaluate a further exacerbation of their dysfunction. Anybody post-surgery, and particularly post-surgery where blood was run through a pump like cabbage. So if you're running the blood through an ECMO pump or a bypass pump, basically the same thing. And also, my friends, running blood through a CRT pump can actually cause myocardial dysfunction, myocardial stunning. It's not non-recoverable, but it decreases the contractile capability of the myocardium. Patients who have ongoing acute ischemia, because that ischemia alters the delivery of ionized calcium into the center of the myocytes. I don't want to make anybody feel like, oh God, I got to go back and study basic physiology. You don't. Just the myocytes, the individual myocardial cells, into the center of the myocardial cell, which is called the sarcoplasmic reticulum. This is where ionized calcium actually assists with the contractile capability of the ventricle. So if you have ongoing ischemia, you have a significant limitation in the delivery of that ionized calcium. Now, I'm not going to give you ionized calcium because I'm not going to help you. It's really related to your oxygen deprivation that's occurring with the ischemia. And then myocardial recruitment. So what we often will see, and it's very similar to surgical related myocardial stunning, is that after patients go to the cath lab and they come into the intensive care unit and they've had an angioplasty or a stent or some other mechanism that re-delivers blood flow, and as we revascularize their myocardium, the myocardium is frequently what we call hibernating or stunned because of all those toxic byproducts that are present there. There is a reduction in the functional activity of the myocardium. So one of the things that's always really important is to remember that inotropes, too much, too long, or inappropriate, can actually make ischemic injury worse. And this visual is from a CPB study, but it's the same for all myocardial injury. So we think about in COVID-19, you may have come into the hospital with an EF of 70%. You were young, healthy, had a great heart. We're talking about Delta, and we're really talking about early Delta. But by a week in the ICU, you had an EF of 15%, a very severe ventricular dysfunction. And it's always a balance. If I'm going to put an inotrope on you, it's always going to be a balance to understand that I'm risking your myocardium by increasing myocardial oxygen demand, but I am also trying to benefit your total system, and that includes your coronary arteries as well, with the inotropic support, which is why all inotrope addition, so if you haven't heard one thing, listen to this. I feel like a preacher. All inotrope addition has to be cautious and requires a discussion and a provider's order before titrating. Because there's so much that happens when we apply inotropic support that we can't see that can actually be very deleterious. So in general, I'm sorry about that. I don't know how my numbers got over each other, but that's okay. So when do we generally consider inotropes? Okay, first and foremost, you should start thinking about an inotrope when your patient has frank or relative hypotension. So relative hypotension means systolic pressure is less than 90, MAP is less than 60 if you're elderly, or 65 if you're not elderly, or you've had a reduction in your MAP of 20% or 30 millimeters of mercury. If you have the ability to look at your patient's blood flow dynamics, you really are most concerned about their stroke volume. If their stroke volume is less than 40, that's a big concern. If you're looking at cardiac index or cardiac output, remember that's stroke volume times heart rate. You can have patients who have a very high heart rate who have an adequate cardiac index, but have an inefficient ventricular ejection. That's why it's preferential always to look at stroke volume. And by the way, if your docs don't care about stroke volume, that's okay. Tell them anyway. You're going to make them care about it. Ultimately, you're going to make people care about stroke volume. Stroke volume times heart rate is a calculation that gives you cardiac output. Cardiac output divided by body surface area gives you cardiac index. So you can look at measurements, which are stroke volume, and calculations, which is cardiac output. And then if you have a CVP, so most of us do have a CVP, if CVP is greater than 10 to 15, or if you're looking at a PAD or wedge and that is greater than 18, that tells you that you have failure to functionally fill the ventricle, that the volume that enters the ventricle actually is creating a static volume in the vein, and that's why those venous pressures go up, because the volume doesn't actually go through the heart, it stays in the heart and backflows into the vein, and that's why you see those elevated pressures. But most important is the evidence that we see of end organ hypoperfusion. Now, I hate to think that any of us are waiting till a patient has altered mental status or decreased urine output. That's terrible. They've already failed of those organs. Why would you want to wait for that? If we talk about acute kidney injury and we apply the Rifle criteria, Rifle for kidney, risk, injury, failure, loss, and end stage, we should be focusing during early times of acute kidney injury. So everybody, I know that was quick. That really relates to kidney function, and I'm really trying to focus on inotrope here. There's just always so much to talk about and so much for us to consider. So anybody who's interested in what I just said, all you do is Google Rifle for kidney. Don't just do Rifle. You'll get all sorts of NRA stuff, and that's fine if that's what you believe, but I'm saying you need to have it for the kidney. So Rifle for kidney, and that tells you about the criteria of increasing creatinine. So way before your creatinine reaches a limit where folks are saying we need to put the patient on CRT or dialyze them, you're already seeing kidney injury, and you see that very early in hypoperfusion states. The other aspect, of course, is lactic acidosis, but we all measure lactate. We don't measure lactic acid, we measure lactate. So we want to look at lactate plus base deficit or lactate plus decreased bicarb as a good evidence of end organ hypoperfusion. And that's really the focus for me, is to look at base deficit, bicarb, anion gap, and lactic acidosis. So I want to just remind you, some of you, those of us who work at Grady, on our arterial and venous blood gases, we do not get bicarb, we get base. Base is a calculation, and it's a calculation that says you must use a certain amount of base to titrate 1 liter of blood to get the pH of 7.4. As the blood becomes more acidotic, that base is in deficit. It's not available for titrating that arterial blood. So here's the way I think is the easiest. This base, also bicarb, just see them all the same here. When base is down, that's in deficit. When bicarb is down, metabolic acid is up. When base or bicarb are down, metabolic acid is up. That's really what you have to remember. Base and bicarb down, metabolic acid up. This base and bicarb are not indicators of respiratory acidosis. They are truly indicators truly of metabolic acidosis. So we love BASE, we love bicarb to give us the information that metabolic acid is up. BASE is +2, meaning that arrow for BASE would be pointing up and the arrow for acid would be pointing down, or deficit, -2, meaning the arrow for BASE is pointing down, you're negative, and the acid is up. One of the most important things I can say to you is that as you're giving fluids and as you're giving vasopressors, you need to keep a clear eye on BASE and bicarb. If BASE or bicarb are going down as you're titrating up, you are not improving patients' blood flow. You're making situations worse. And that's why you've got to have a bigger view about what it is you're trying to do for the patient. It is also important to remember that we look at filling pressures, right? Right heart filling pressure, CVP, left heart filling pressure, wedge or PAD. As the filling pressures go up, what that's telling you is that the volume that is attempting to fill the heart is static in the veins. And as it's static in the veins, it will promote fluid extravasation and, by the way, significant severe disruption of the endothelial barrier. So we never really want to see filling pressures up high. We never want to promote destruction of the endothelial lining. We never want to support that the patient now has interstitial volume. And sometimes our providers will say, it doesn't matter how edematous he is, he still needs volume because he's arterially hypovolemic. No, if you've got volume and it's in the veins, your problem is that you're not moving that volume to the arteries. That's why you need an inotrope. That's why you think about an inotrope. Your filling pressures are up. You're extravasating volume to the interstitium. Your patient looks like the Michelin Man. He now has abdominal hypertension. He has wet lungs, a wet brain, a wet heart, and he has arterial hypoperfusion because both his right and or his left heart are not functionally accepting the volume and ejecting it forward. Now, before I even start talking about the particular types of inotropes and how we use them, I just want to remind you that inotropes are not without harm. So again, if my patient has an acute ischemic event where they already have oxygen starvation because they have myocardial ischemia, that would be like a STEMI. I'm going to be less likely to want to start an inotrope, even if their EF is low, because if I give them an inotrope, that inotrope is going to increase myocardial oxygen consumption. That's what this is. This is VO2 is oxygen consumption, and the M in front means myocardial oxygen consumption. So that's why you really have to appreciate situations are different for, and require different intervention. What that means most particularly is you won't be getting dobutamine from me if you are in an ischemic state with a STEMI, and I believe that your stroke volume is poor and your EF is poor. I'm going to want you to get to a cath lab. I would probably recommend mechanical circulatory support. For us here at Grady, that would be an Impella. For others, that might be VA or VV ECMO, depending on the patient. But you really need mechanical circulatory support. If you are ischemic, you don't really want to increase myocardial oxygen consumption. It's also really important to remember that you might not be ischemic visually. I might not see that you're having a STEMI, but if your heart rate is greater than 110, you've increased your myocardial oxygen consumption. So that's another really important concept here is when we see patients become severely tachycardic, I want you to imagine that's just like having a complete occlusion of their left main. Now, it's not an occlusion. It's just that it's increasing myocardial oxygen consumption. And the other aspect here is that you have to have time for the ventricle to fill with volume. That's called the diastolic time, a diastolic time or the diastolic interval. Diastolic time is when the ventricle fills with volume. In tachycardia, the ventricle has little time to fill with volume, so your stroke volume will go down profoundly. So it is important to consider that you might need, in this case, and then people are going to totally flip out, and they do. It's like, I might put you on a beta blocker, and that beta blocker having a higher specificity to your sinus node to reduce your heart rate. And then I might put you on a beta stimulant, Dobutamine. And sometimes nurses at the bedside will say, sometimes doctors too, and APPs, well, why are they on a beta blocker and a beta stimulant? Because we're focused on two different groups of receptor sites. The beta blocker, we're trying to block the sinus node receptor site. It will have some secondary effect on the myocardium. And we're going to use Dobutamine as a beta 2 stimulant to increase myocardial contractility, and it will have some secondary effect on the sinus node. So there's no beta stimulation that's going to be completely pure, but sometimes you have to be at the bedside. You have to say, tachycardia is a compensatory response, but if my patient has cardiac dysfunction, tachycardia is discompensatory. So if you're in sepsis, tachycardia is compensatory. If you're in hypovolemic hemorrhagic shock, tachycardia is compensatory. In cardiogenic shock, tachycardia exists for the same reason. You have a poor blood flow, but the tachycardia itself is decompensatory. We have to pay a lot of attention to that. Now, when the heart is beating fast, or when I'm using high degrees of positive pressure breathing, that's going to compress the heart, right? When the heart beats fast, I don't have time to fill it. When I use positive pressure ventilation, it compresses the heart. That's going to significantly decrease the volume that fills the ventricle. That's called the diastolic perfusion pressure. And it's also going to increase the tension of the wall, which again increases myocardial oxygenation. So we also know that tachycardia can cause exacerbated cellular suicide. Cellular suicide means all cells die at some point. They have a program. But apoptosis, that's the term that's used, means that that program is upregulated. So cells die before their time. That's what apoptosis is. And because you might have cardiac cells dying, that's going to decrease myocardial recovery. Now, having said that, let's talk about inotropes. Let's think about inotropes. So first and foremost, we can all appreciate inotropes increase myocardial contractility. Normally, when we talk about inotropes, we are referring to positive inotropes, right? Increasing the strength of the muscular contraction. Now, along with that strength, remember, will be a reduction in compliance and an increase in oxygen demand. So you got to be aware of that. And again, you got metabolic acidosis. I'm going to put you on Dobutamine. You are not going to be under my care with a hemoglobin of 8. I will call every attending and the chief to try to get you hemoglobin because I put you on a positive inotrope. I need for you to have better oxygen carrying capacity. Remember, I'm not looking for any more than 2 units, and I'm okay with 1. I'm grateful when people give me 1 because I want to be sure that I'm balancing that increase in oxygen demand with some oxygen supply. And hemoglobin carries oxygen. Negative inotropes decrease the force of muscular contraction. Now, generally, you are not trying to decrease the force of muscular contraction, but it does happen. When you're hypocalcemic, when you use beta block therapy, you're going to reduce inotropic function. So again, you have to be aware of that. As you add beta block therapy to a critical patient, all of a sudden, do they become hypotensive? Then you say, oh, the problem is, their arteries. Now I'm going to put them on Levophed. But you've got to look back here and say, I used beta block and reduced the force of their mechanical contraction. Okay. Now, what I want to make sure we appreciate is at the end of all positive inotrope, whether it's sympathetic stimulating, that would be Dobutamine or low-dose dopamine or low-dose epinephrine, or whether it is the phosphodiesterase inhibition, that's Milrinone. So all 4 of the primary inotropes, not talking about DIG here, that's an oral agent. It's a lousy inotrope, shouldn't use it for this. Might have to use it now, patient, maybe, but we're not talking about that. We're talking about the 4 basic inotropes that we use in the United States. There are others, but the ones we use here, they are all about the level of calcium in the sarcoplasmic reticulum of the muscle cell. So I want to make sure you appreciate what I'm saying to you, that you have to assure when you're using inotrope and you're using low-dose epi for an inotropic purpose, low dose dopamine for an inotropic purpose, dobutamine for an inotropic purpose, or Milrinone for an inotropic purpose, your patient must have a normal ionized calcium. Don't even start if you haven't assured that. Because, my friends, it is all about calcium. So these are kind of intense slides, but really, really important to remember that the electrical depolarization, both in the atria and the ventricle, is ultimately about one thing only, and that is opening the calcium channel. So you have electrical stimulation and the transfer of electrical information, but it is all about opening the calcium channel. So when I open the calcium channel, my cellular calcium goes up. Look what happens here. The sarcoplasmic reticulum calcium goes up, and then that calcium is mobilized back out of the cell. So efflux much greater than influx, but it's the influx which actually allows me to have contraction. Now, I'm not asking anybody to explain the calcium channels, sodium channels, potassium channels, and automaticity or anything else. I want you to appreciate that at your bedside, you need to optimize filling for your patient's heart. You're a trauma patient, you still have a heart. You're a neuro patient, you still have a heart. This is not just about cardiac patients. We have to try, if possible, to recognize the compensation of tachycardia and treat what the tachycardia is compensating for. We have to try to get that heart rate down. We have to try to assure that there is normal electrical depolarization, that you're not in AFib, you're not in A-flutter. Of course, not in VTAC or VFib or V-flutter. That makes perfect sense. We have to be sure that the patient has normal calcium and normal ionized calcium. That is critically important. At the beginning of every shift in a critical patient who's on inotropes or vasopressors or has questionable blood pressure, the first thing you need to do is look at their calcium. So again, positive inotropes are going to support myocardial contractility. And these are the primary inotropes that we use, okay? Hydropyridine, PDE, and actually the bipyridine derivatives, Milrinone, come under PDE. That's what we refer to them as. So theophylline is not something we use anymore. That's old. Milrinone comes under PDE. So cardiac glycosides like DIG, PDE like Milrinone, catecholamines, and of course, just remember that your negative inotropes, you're not using those agents with the idea that you want to decrease contractility. You're generally using those agents to control heart rate or to control dysrhythmia. So beta blockers. Okay, well, beta blocker, it makes perfect sense. I am blocking beta. Beta is what I need for contraction. When I block beta, I have a reduction in contraction. Calcium channel blocker, okay. Calcium is necessary for contraction. So when I have a patient calcium channel block, like cardizem, diltiazem, I'm going to have a reduction in contractility. So just understanding you need beta and you need calcium. So when those are blocked, contractility will go down. Now, sometimes that's not a problem, but a lot of times it is a problem. And then class 1A and class 1C antiarrhythmics. Now, in general, you are not using those agents. Those agents are sodium channel antagonists. Class 1A is lidocaine. Class 1C is, I think, pronestal. So in general, you're not using them. Every once in a while, when you have refractory ventricular dysrhythmias, your cardiologist or your electrophysiologist might get involved, and they may use lidocaine, or they may use pronestal, or they may use quinidine. We don't do that as a natural flow, but those agents also will be negative inotropes. So really, really important for us to appreciate that much of the newer recommendation says, of course, we think about inotropes with decompensated heart failure and cardiogenic shock. Post myocardial infarction, no longer in the ischemic state, cardiomyopathy, but you might be surprised to recognize that it is also considered to be a category A agent in septic shock. So now just taking a quick look, right? Dobutamine as a sympathomimetic, stimulates beta 1. It's the most commonly used because it is predominantly beta 1, has some beta 2, and at higher doses, much higher doses, alpha property. Now, alpha, remember, is in the artery, and alpha stim causes arterial constriction. Beta 2 stim causes arterial dilation. Now, why this is important is because our goal is always to use dobutamine for the purpose that it is for, and that is beta 1. Anything above 10 is going to involve more beta 2, and anything above 15 is going to be alpha. So I want to make sure you hear what I'm saying to you. Dobutamine is not a titratable drug. You do not titrate dobutamine. And if in July you have a new resident who says, let's titrate dobutamine to 20, you will say no. You will not do that because dobutamine is a rate-related agent, and we use dobutamine for inotrope. So less than 10. Patients who don't have heart failure, typically they're going to need less than 5. Patients with heart failure typically are 5 to 10. Anything higher than that, you're going to cross over into other stimulating surfaces. So you need to be aware. I want to say it again. Nurses do not titrate dobutamine. And if you have not got a heart failure condition, dobutamine typically at a dose less than 5 is going to be effective for you. If you have heart failure, typically the dose of 5 to 10 is going to be effective for you. We as nurses will not accept, unless it is the chief physician and you've had a discussion, you will not accept an order to have dobutamine greater than 15. And I would tell you not greater than 10, but not greater than 15. And that's pretty much embedded in everybody's MARs around the world. Okay. Now there are other sympathetic agents like epinephrine, like norepinephrine at different dosing regimens that are going to have inotropic properties, but they're not used primarily for inotrope. Dobutamine is used for inotrope. Milrinone is used for inotrope, but Milrinone has a more significant effect on vasodilation of the arteries. So in our units, what I would always encourage, is that if you have a physician or a provider that says, we're going to start on Milrinone, always have a discussion. Are we using Milrinone alone? Sometimes we'll use Milrinone alone because it has such a profound effect on the pulmonary artery, and we want to see arterial dilation. But Milrinone is a weak inotrope. So frequently what we will see, and we should always have a discussion, is if we're going to use Milrinone, that we're also going to combine that with low-dose dobutamine. And we should be always having that discussion. You don't write the orders, but you do have to be really intelligent about how orders are applied at the bedside. I am not telling you to refuse, to have a fight, to get fired. I'm saying protect the patient. Always have a good discussion. Now, again, DIG is not a very good inotrope, but sometimes patients might take it outside of the hospital because it's the only oral inotrope that we have. Then you want to remember that the agents that decrease contractility, that's not what you chose, but common agents that you use, any drug that has a LOL, like metoprolol, labetalol, carvedilol, any drug that has a LOL is a beta blocker. And a beta blocker, you might be using that to reduce the heart rate, but it's going to also reduce the contractility of the heart. So pay a lot of attention to your patient's stroke volume. If you have an A-line, pay a lot of attention to the systolic pressure. And instead of adding a vasopressor, maybe we need to back off on these agents, right? Because that they cause a very significant reduction in myocardial contractility. Now, they do have some effect on the arterial tone as well. That's really, really important. And then, of course, diltiazem, verapamil, cardizem, all calcium channel blockers. So yesterday I talked about the alpha-1 adrenergic. Today I'm talking about beta-1. Beta-1 for the heart, increasing inotropy and heart rate, and beta-2, which actually can cause minimal vasodilation. So I'm going to look at The two primary inotropes we use, not really talking about dopamine because it's so rare that you use it. Epinephrine, even at a really low dose, alpha equals beta. So you're going to have vasoconstriction plus positive inotrope. Dobutamine, beta 1 is greater than beta 2 in the usable doses of less than 10. You start to lose some of that when you're above 10. You start to encourage alpha. And remember, Milrinone is a phosphodiesterase inhibitor. So now, just taking a look at the receptor targets. So alpha receptors reside in the artery. So I start epinephrine, I'm going to have arterial constriction. I'm also going to have beta 1 stimulation. I don't affect any of the dopaminergic receptors or the PDE receptors. Dobutamine, no alpha in a reasonable dose, right? Remember that, in a reasonable dose. It's pure beta, pure beautiful beta. And Milrinone doesn't have alpha, beta, dopaminergic, just PDE. So again, I just want to remind myself that this is beta, but it's both beta 1 and 2, that if I start you on dobutamine at a low dose and you're tachycardic, I might need to put you on a lower dose of dobutamine and put you on Milrinone. Milrinone doesn't affect your heart rate. But yet again, I'm going to remind you about calcium. The first inotrope that we should always consider for a patient is calcium, making sure that their ionized calcium is appropriate. Remember, serum calcium should not be treated because serum calcium is the total calcium that's bound and unbound. So calcium is carried by albumin and other proteins, and you're going to release calcium when you're hypoalbunemic. Your serum calcium will be down, but your ionized calcium may be normal. So I always want to think about ionized calcium. There are other things we can do to organize our mind to give calcium appropriately. Again, not really part of this talk because it's a lot of information. Now, I'm going to do my very best here to talk about something that I want to make this simple. So we all learned about thin filaments and thick filaments, right? Thick filaments have these myosin heads, and the myosin heads connect to the thin filament. When calcium is entered into the cell, it binds right here at the troponin level, and that shifts the thin filament and breaks that bond or stretches that bond. And that's actually what promotes contraction. So again, really, really important. You must have appropriate ionized calcium. Every critical patient deserves you to look at it. Every patient who's hypotensive, every patient who has a low stroke volume, you need to look at it. Okay, next you think about epinephrine. At very low doses, it's going to be beta, and it's really potent. It also, at whatever dose you use, affects metabolic rate and insulin resistance. So epinephrine significantly increases metabolic rate, and it promotes insulin resistance. So your patient will immediately, they're going to be hypermetabolic, they will become hyperglycemic, and it's always important to remember that glucose in the blood is not glucose in the cell. So you must consider that when you're evaluating those patients. In general, epinephrine is used in anaphylactic shock. It's used by cardiac surgeons, and it's used by traumatologists or others in sepsis as a second or third line agent. But it causes a lot of problems. So again, I just want to remind you, in the pursuit of blood pressure, think twice before adding epinephrine. Is my patient acidotic? Then I shouldn't go to epi. I need to go straight to vasopressin. Maybe I have to go to angiotensin. But once I add epinephrine, that's going to increase coronary ischemia. It promotes significant renal vasoconstriction. It increases oxygen demand at the tissue, and it promotes insulin resistance. Okay, now sometimes it's just because all you're about is pressure and you're not looking at the bigger picture. Do I have adequate stroke volume? Do I have ventricular efficiency and ventricular response? What's my heart rate? Is it essential to keep the heart rate up? Can I get the heart rate down? That'll improve stroke volume. Is the patient an AFib? If he's an AFib and he's sick, that's a life-threatening dysrhythmia. Pay attention. You're an AFib and you're critically ill and you weren't in AFib before. that means that you've lost 50% of ventricular filling because your atria is fibrillating. You got to get that patient out of AFib. So I'm kind of all about, you've got a new onset AFib, not chronic AFib, and you're critically ill. I want you to be cardioverted. I don't want to waste a bunch of time giving you drugs. All your ions are messed up. I want to cardiovert you, because if I can obliterate that AFib, you're going to have better ventricular filling. So again, before you go up and up and up and up on your vasopressors, think about what else is going on for the patient. Then we look at dobutamine. Dobutamine is primarily beta-1. It's significantly more beta-1 than beta-2. Beta-1 is inotropic, beta-2 is pronotropic heart rate, and mild vasodilation at less than 10 mics per kg per minute. At higher doses, the peripheral effect now becomes vasoconstriction. You should not start patients on dobutamine if systolic pressure is less than 80. You need to try to get the pressure up above 80. Give some calcium, start them on low dose norepinephrine, and then add dobutamine, okay? So get their arteries under control mildly, and then add dobutamine. But don't remember, it can make ischemia much worse. So be clear that the patient doesn't have ST segment elevation or even ST segment depression, okay? Patients who are on chronic beta blockers, who are acidotic, who are profoundly hypoxic, they're going to have a reduced response to dobutamine because that affects the beta stimulation upload. Very common to see when you start patients on dobutamine, especially if you start at 5. So, you know, you're a 30-year-old guy with an EF of 20% after a motor vehicle collision and sepsis. You don't have known heart failure. I would never start you on 5 of dobutamine. I talk to my doc and I say, let me start at 1.25. In 5 minutes, I'll go to 2.5. 5 more minutes to 3.75, and let's see where we are. I'll ultimately get to 5 if that's what the patient needs, but he doesn't have known heart failure. So is it okay to start low? Now, by the way, you got to be sure that you have an order for that, because you'll get dinged by CMS and JCH if you don't have an order. But best practice is to start as low as possible. If you have a known history of heart failure, you have unresponsive beta receptor sites, we're going to use a higher dose of dobutamine. We're going to start with 10. Here's a time where you may go above 15, but remember, only with an order, and typically with a cardiologist order, with a chronic heart failure. Otherwise, never, 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 never. Okay, phosphodiesterase inhibitor Milrinone. Very important to remember about Milrinone. It's a vasodilator first and an inotrope second. So really, really important. You're going to see systemic vasodilation. You're going to see pulmonary dilation. Now, that means your calculated SVR will go down, but that also is because hopefully your cardiac output goes up. Milrinone does not have a significantly strong effect on your cardiac output. It's minor. And that's why generally the recommendation is to use Milrinone plus dobutamine. And typically the reason we use Milrinone is we don't want your heart rate to go up, or because we believe we need to open particularly the pulmonary artery. It's significantly impactful in reducing right ventricular afterload, meaning it opens the pulmonary artery. And we can use also Milrinone is highly linked to improvement in non-ischemic cardiomyopathy. So again, the advantage, and not well-founded, not well-proven, is that less heart rate increase, less tachycardia, and less atrial fibrillation, better efficacy for people who are on beta block therapy. So you know your patient, he's been on beta block for 5 years, he needs an inotrope. Dobutamine is not going to be effective. He needs Milrinone. And then the lusitropic, which is relaxation and vasodilation, particularly in the pulmonary bed. Now, the thing about Milrinone is that you have to saturate the PDE inhibitor receptors, and you have to do that with a loading dose. The loading dose is 50 mics per kg administered over 10 minutes. So you set it on your pump to be administered over 10 minutes, and then you move over to a drip at typically at 0.375 mics per kg per minute. Lots of times folks don't want to use a bolus because when they give a bolus, guess what's going to happen? The patient is going to have vasodilation and they're going to drop their blood pressure. But the problem is that without the bolus, you're not going to achieve the inotropic effect for about 4 hours. So I've got a critical patient who needs positive inotropic support. My doc says, I don't want to start them. I don't want to give a bolus because their blood pressure is a little unstable and I'm afraid they're going to become hypotensive. Okay. Well, you need to expect hypotension. And you know what you need to be able to say? My friends, I understand that bolus is going to probably cause hypotension, but I'm going to treat that hypotension, doc. Just write an order for norepinephrine, and I'll start norepinephrine if the blood pressure drops. I'm staying in the room. I'm giving a bolus. I got to stay in the room. If you don't give a bolus, it's going to take too long for the drug to become active. And at an hour or two, people are coming back to the room. They're saying, let's increase the Milrinone. No. We're not going to increase the Milrinone until at least 4 hours if you didn't give a bolus, because I didn't saturate the sites. Now, the problem with Milrinone as well is that it can take 12 to 18 hours to clear out of the system if the patient has been on Milrinone for 24 to 48 hours. When I discontinue the Milrinone, it's going to take some time for it to clear. That's also the problem with Milrinone. People are afraid of it because if the patient drops their blood pressure, they can't really turn it off and get it to disappear immediately. Hey, man, I know you. I've been a nurse forever. I know you and I know what we do. We are not afraid of vasopressors. So why are we so worried here? If I start you on Milrinone, you drop your pressure, I can give you calcium, which will be somewhat of an antidote, and because it will increase calcium uptake in the arteries, and that will help me to maintain some vascular tone. But more importantly, I can just start you on low-dose vasopressor. And I'm going to be able to wean that off, hopefully, when you take Milrinone off and it dissipates, right? I'm going to turn the Milrinone off, but I'm going to stay on the vasopressor probably for another 12 or 24 hours until that Milrinone has disappeared. If you start your patient on Milrinone, they're already on a vasopressor, expect that you're going to need to increase. It is common to use alpha-stim catecholamines with Milrinone to decrease hypotension and improve contractility. So the truth of the matter is, I would be cool with you being on Dobutamine, low dose, Milrinone with a bolus, and norepinephrine. That's polypharmacy, and it's a really great way to manage that patient. Now, we like Milrinone because it causes some pulmonary dilation. So that really helps the right heart unload. And Milrinone really is the drug of choice with right ventricular dysfunction. Now, I'm not just talking about an RV infarct or right ventricular failure known. I'm talking about when you got a lot of positive pressure on board, you got patients on APRV or pressure control inverse ratio. You might need some Milrinone to help dilate the pulmonary vessels and unload the right heart. Has less tachycardia, less dysrhythmias, and a much significant decrease in the oxygen requirement of the myocardium. It also works really beautifully together with catecholamines. So really, these are the two inotropes, Dobutamine and Milrinone. Milrinone is weak. It's inappropriate in general as monotherapy, meaning all by itself for shock, unless it's a right ventricular dysfunction. And remember, Dobutamine, we have to be concerned because if we start at a higher dose, you most often are going to have significant tachydysrhythmia, and that's going to limit your Dobutamine. So I want to remind you, our goal is we want to increase your vascular tone. We can do that with vasopressors and with inotropes, but never to limit your stroke volume. So you got to always check on that stroke volume and make sure that it's not going down when you are enhancing vascular tone. And remember, I'm going to give you Dobutamine and Milrinone. Now I've got to add in some norepinephrine. I don't want to titrate up on the norepinephrine so much that I now have limited the effects of Dobutamine and Milrinone. And ultimately, our goal is to increase your stroke volume. Increase your stroke volume, hopefully the heart rate goes down. As we increase your stroke volume, you have adequate hemoglobin and adequate SAT greater than 88%. you're going to have an appropriate delivery of oxygen, and that's going to help decrease your cellular metabolic dysfunction. Because quite honestly, shock is always about cellular metabolic dysfunction. So our end goals, remember, for me, it's all about the base, right? I want to get your MAP to 65 to 75, your index, if that's what I'm looking at, greater than 2.5, your SVO2 to 65%, but you must not have a base deficit. You must have a normal gap. You must normalize your bicarb, because those are the indicators for tissue perfusion. So we think about successful management, and we just remind ourselves, if you have a bad right ventricle or you have a high pulmonary afterload, here we have that when we have pulmonary embolism, when we're using extraordinary positive pressure, PEEPs greater than 10, APRV, oscillation, pressure control inverse, patient needs pulmonary dilation. Okay, here we just are increasing the contractile state. We can do that with dobutamine, epinephrine, PDI. We don't use isoprel anymore, although it's still a relatively good inotrope, but it has such tachydysrhythmia associated with it. And then, of course, the maintenance of your blood pressure by using vasoconstrictors. So actually, pure polypharmacy. So it might be dobutamine plus Milrinone plus a vasopressor. And I might even add in Flolan here if you had a right ventricular infarct. I need pure polypharmacy, not monotherapy. Monotherapy doesn't work very well when we're talking about hemodynamics. All right, so now we're just going to take a very quick look at a patient. This is an abbreviated form. This is a patient who was admitted to the ECC in full-blown cardiac arrest. He was 20 minutes before return of spontaneous circulation. He was given high-quality CPR. Compressors were rotating every 120 seconds. He got epi every 3 to 5 minutes per ACLS guidelines. He got IV fluid. Once he came to the ECC, IV fluid, epi ×1, bicarb, calcium, multiple rounds of CPR. They actually put a Lucas on him. So that they were really clear. His VBG had a potassium of 7.7 and a pH of 7.07 and a blood glucose of 221. Okay, now he has severe metabolic acidosis. This was just from the note. I didn't have any other information there. And his potassium is up, but we are going to assume that potassium is up, A, because he's gotten shocked, and B, because he has metabolic acidosis. Okay, well, he's got metabolic acidosis. He achieves return of spontaneous circulation. He gets 5 units of insulin because he's hyperglycemic. He has a pericardial effusion without tamponade physiology, a decreased EF. He has diffuse curly B lines on his chest X-ray. They decide to intubate. And all of those considerations that you talk about when you got PEA, hypoxia, hypovolemia, hypoglycemia, hypo or hyperkalemia, and acidosis, all those things were considered. Here's his chest X-ray. So not a big surprise. He's got a big old boggy heart, right? He's got a very small thoracic cage with a really big boggy heart. So then he gets admitted up to the CVICU. It's a very lovely note written by the APP who admitted this patient, who explains what happened to him. But I want to focus on this. He gets up, he goes upstairs into the CVICU. He arrests as soon as he gets there. Lucas is applied. He gets ROSC, activate code ICE, our TTM protocol. His PO2 is 82. His pH is 6.98. PCO2 is 86. So he's got respiratory acidosis. We can fix that pretty well by better breathing. And he has a base deficit of -13. So remember, when base is down, acid is up. And base here is way, 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 way down. This probably correlates to a bicarb of around 5. Sodium 128, potassium 7.7. Hyperkalemia was medically temporized. They gave insulin, they gave bicarb, they drew cultures, they did a CT of the head and the PE, but while in the scanner, he coded again. He has, this is all ED, I'm sorry. So ROSC returns, so that's subsequent PEA arrest ×2. His EF is now 15% on POCUS, and he started on dobutamine, admitted to the CVICU for targeted temperature management. And in the ED, what happened at 0023, he hung a bag at 5 mics per kg per minute, which is what it was ordered for. And then the nurse titrated up at 125 to 7, titrated up at 159 to 12.5, and titrated up at 2 to 17.5. Okay, now on interview with the nurse, so this is just discussion, guys, so don't anybody get upset. When I spoke with the nurse said the resident told me to go up on the dobutamine. What was the resident's name? I don't know. And the resident didn't write the order. So of course, as we know, that when one person says one thing and one person says another, it becomes very hard, very difficult to actually evaluate what occurred. So here's what I'm saying to you. You will not titrate dobutamine without a written order. You love your colleagues, you want to take a verbal order, you can't do it. They've got to write the order. You need it, you got to write the order right now. I know we're in a crash situation, you have to write the order. I can't allow you to tell me this orally and then not place the order in. And sometimes, the orders and the notes, et cetera, the docs can delay 24 to 48 hours before putting them in. We never got a doc who wrote that he had asked for that dobutamine to be increased. This was a pretty young nurse. I don't think that nurse would have ever increased dobutamine on their own because they really didn't know what dobutamine was for. I don't think the nurse increased the dobutamine. I think that nurse was told to increase it, but there wasn't an order. Okay, so the doc wrote the order and then he discontinued it. Okay, so now the patient goes upstairs. Intubated on 100% FiO2, fentanyl drip, not following command. Heart rate is 170. Patient's on 17.5 of dobutamine. Epi is at 24. Vaso is 0.4. Patient was on norepinephrine, was not on norepinephrine, just epi, vaso, and dobutamine. Heparin was started with concern for PE. Patient kept arresting, did not tolerate TTM. Patient's note and family is involved in a discussion. They want him to remain a full code. So there are 3 primary points to note here. And what are they? So I know you already know what they are. The fact that your patient was significantly and profoundly acidotic, right? Why wasn't he on a methodology to help blow off his CO2? We don't know that. We also know the patient is on 17.5 mics of dobutamine and epinephrine at 24. So by the way, the ischemic burden to this patient's myocardium was profound. Profound. This was not a good management scenario. And why was he on epi and vaso and not on levo? That's the other question. And this is in the ED. So it's really important to remember we weren't there. I couldn't find in the chart, and I've reviewed this chart a while ago, so I didn't review it right before this talk, but I couldn't find in the chart any explanation for why epi was the first agent. Couldn't really figure that out. Okay. And very, very important to appreciate that his profound metabolic and respiratory acidosis, but his metabolic acidosis actually made him unable to respond to his sympathetic stimulation. But quite honestly, I think that we would all recognize that having dobutamine at 17.5, even with the resident, and that is what happened. And he did go back and ordered it, and then he discontinued it. I think the resident discontinued it, but he didn't communicate it to the nurse because he probably talked to his attending, and his attending said, "Get that dobutamine off." So the patient continued on the dobutamine. Now that nurse was doing the best job that they possibly could. This is not anyone's fault. I don't put this here to talk about fault. I put this here to remind you, you never increase dobutamine above 15. And I would recommend never above 10 without a direct written order and a discussion about what the goal is, because greater than 10 of dobutamine is going to put your patient at risk. It significantly, profoundly increases oxygen consumption, especially if a patient already has hyperlactatemia. His lactate levels were like 7. So Again, this is why we don't titrate dobutamine without an order. So I'm going to end with this little case. This is just for you to think about. 56-year-old man, hypertension, diabetes mellitus, type 2, coronary disease, severe LV dysfunction, has very nice proper management of his heart failure and his coronary disease with good medication management, but today presents in heart failure class 4 with shortness of breath, decreased urine output, and drowsiness. His jugular veins are elevated, he has ascites, and he has 4+ bilateral pedal edema. So the assumptive diagnosis is he has acute decompensated heart failure, AD, acute decompensated heart failure with type 1 cardiorenal syndrome, renal failure secondary to the heart failure. He's relatively hemodynamically stable. He gets diuresis, vasodilators. And at that point, would you add an inotrope? No, because he's stable. But then he gets worse. So once you see worsening renal function, mentation in a heart failure patient, we're definitely going to want to add an inotrope. And of course, the inotrope we're going to want to add here will be dobutamine. So this is available in the handout. This is just a lovely, I didn't make it. And I can't remember who I got it from. It's so beautiful that just talks about drug choices, when to start it, why do you need it, what the dosing is. It's really beautiful. It's in your handout. And I just want to remind you quick tips for sepsis. Generally consider best to start with neo, vaso, and then epi. Providers may make other choices. They may say neo, epi, vaso. Sometimes providers say epi, vaso, neo. It's okay. Don't sweat the small stuff. But just remember that for inotrope, you should always consider dobutamine, not epinephrine. And epinephrine at 24 was not an inotrope. It was a profound vasoconstrictor. So remember, for inotrope, we should always consider dobutamine at the lowest possible dose and provider order only for titration. When you apply Milrinone, when Milrinone's been ordered, consider adding dobutamine. And by the way, always, always, always optimize calcium. Don't forget it. Thank you very much for your time, for your energy. The handout is in the chat box. So at the top of the chat box is the handout. And if you're on your computer, you should be able to see that. Normal minute ventilation. Thank you for that lovely question. Normal minute ventilation. I hope Zoom user is still on here. Maybe not, but oh yes, Zoom users are. Normal minute ventilation is frequency or respiratory rate times tidal volume, and normal minute ventilation is 8 to 10 liters. So if I'm giving you aggressive bicarb, I want to appreciate that bicarb dissociates into CO2. So while I'm treating metabolic acidosis, I may cause respiratory acidosis. And that's what you saw with that patient who had his CO2 at 86. So what we're going to want to do is increase his respiratory rate. That's typically what we'll do. And shorten his inspiratory time, which means we're going to flow the gas into his lung fast as long as the lung is compliant. So you'll speak to the therapist and say, I'm giving all this bicarb and his CO2 is up. What can you do to help me adjust for the CO2? What they'll do is they'll titrate up on the respiratory rate. They might go up a little on the tidal volume, and they'll shorten the inspiratory time, allowing time for exhalation. Okay. So I think that's the only questions we had. I think everybody, unless you have a question, you're welcome to unmute and ask a question or to type into the chat box, either way. All right. So no questions. Oh my goodness, it's 20 minutes after 5. Oh my gosh, I'm so sorry. Thank you very much. I hope I'll see you tomorrow for the 411 on the 911. We're going to look at, I think we're going to look at 2 case studies from our emergency department. They will be so fantastically interesting for us. We really appreciate that you come and that we're all growing together in knowledge. Thank you, thank you, thank you so very much. Yes, you will have access to this online because, thank you for reminding me, I'm going to stop the recording and you will be able to